Good afternoon, everyone. I'm Priyanka. Today, I'll be presenting a long case. Uh, the patient, 11-year, 7-month-old girl, third by birth order, born out of non-consanguineous marriage, resident of Thane, Hindu by religion, right-handed, brought by parents with complaints of abdominal pain 12 days back for 3 days, fever 10 days back for 2 days, and difficulty in walking since 7 days. The child was alright 12 days back when she developed abdominal pain, dull aching in left iliac region, not associated with vomiting or loose stool, not associated with aggravating factors, relieved after 3 days after taking medication. Fever 10 days back, not documented, moderate grade, 1 to 2 spikes per day, intermittent, not associated with chills or rigor or rash, relieved on its own, active in interfebrile period, not associated with cough, cold, burning, micturition, or loose stools. Later, parents noticed that the patient has difficulty in walking, informed that patient is dragging her left leg while walking, and the child has difficulty in running. 2 days later, patient had fall while walking towards side to side and uh, weakness in legs, difficulty in standing from uh, patient had fall while walking towards side due to weakness in legs, difficulty in standing from squatting position, required support for standing from squatting position, child required support while climbing stairs. Parents also noticed there was slippage of slippers while walking. This then progressed to a present state where the child cannot walk without support since 3 days. There is pain below knee in left leg since 3 days. The child has difficulty in wearing pants and slippers. The child requires support from getting up from bed. Inform that the first child turns to left side, then takes support and get up from the bed. There is no difficulty in standing from sitting position. There is history of tingling sensation present in bilateral lower limbs since 5 to 6 days. A history of back pain present. No history of history suggestive of cranial nerve involvement. No history of altered sensorium or loss of consciousness. No history of bowel or bladder incontinence. No history of seizures. No history of abnormal movements. No history of trauma. No history of drug intake. No history of recent vaccination. No history of vomiting or headache. No history of similar complaints in past. No history of Cox or Cox contact. No history of similar complaints in family members. For the above complaints, the child was admitted in some other hospital. Neuroimaging was done and referred child to our side for further management. Past history, there is no previous admission. ANC history, uneventful. Birth history, uneventful. Developmental history, the child is school going child, studies in 7th standard and has good scholastic performance. Immunization history till date, dietary history, mixed diet from family pot. Family history, there is no significant family history.
Okay, so come ahead. So what do you make out of that abdominal pain? First complaint. You heard that abdominal pain, dull aching, left iliac region, relieved after 3 days after taking medication. Come ahead so that it's easy to interact.
So either the pain can, as the pain is from the left iliac region, it can be from the rectosigmoid junction or any or any lymph node that could have been there. Then
It can be a prodromal symptom or a dull aching superficial sensation that the child uh, is getting, which she complaining of like abdominal pain.
So basically, in general, we are revising what should be our approach to abdominal pain. So, what should be your thought process? So, first thing that you should be able to answer in your mind is what is the classification or division in your mind? You are trying to decide where this pain is coming from. So, what you said, you're trying to say that the pain is coming from the abdominal wall and the child has kind of misunderstood or something like that you are saying. But that's what you have to decide where the pain is coming from. So your first division in your mind is parietal or visceral pain. Okay. How will you differentiate clinically whether it's parietal or visceral pain? Forget this child, in general, I'm asking any child who comes with abdominal pain. This is we are on history. So basically, more painful, less painful. So not really, because in the same child you don't have a comparison. Na? So how will you decide more painful, less painful? Both can be quite painful. Yes, visceral can be referred, but that is, you will think of that only after you decide this is visceral pain, right? So basically, visceral pain is poorly localized and parietal pain is sharply localized. Okay. So visceral pain is vague and dull aching and all that. Parietal pain is sharp and very clearly localized. So that is one big difference that you have to make out. Now, next step is if it is visceral pain, then what is your thought process? Anatomically, what are the structures in that area? Which structure is it coming from? Right? So, what could be the structures in the left iliac fossa?
Colon, lymph node, mesentery.
So, left iliac fossa, most common is the colon, right? So, what will give you pain from the colon?
Mass, or if there is impacted, matlab fecal.
Very good. Fecal impaction. So, commonest cause of left iliac pain is fecal impaction, right? There are no other major organs there. I mean, lymph nodes are there everywhere, but nothing else otherwise, right? So, you at the moment, so now if you've gone through this thought process, at that stage you will ask a question. And what is that question? Is she regularly constipated? Is she passing stools every day? That might give you. Secondly, what was the severity of this pain for 3 days? Was it troubling her? Was she
It is very little pain, not troubling.
very good? So it was mild pain. So again, point is constipation pain is like on and off. Child will say pain 5-10 minutes, half an hour later forget, then again little pain, then forget. So this was not very severe disabling pain, right? So maybe we just leave it at that, constipation to be confirmed. We don't know whether it's related to this subsequent complaints or no. We'll see later. What about fever? Now, next complaint is fever.
The fever is also mild to moderate grade, 1 to 2 spikes per day, undocumented, and it relieved on its own, not with medication. She does not require any medication for that.
So, what does that tell you? Anyone, all of you can participate. Come ahead if you want.
Less likely to be infective. And be inflammatory also due to disease. Inflammatory.
Usually, inflammatory pain is also higher, like prominent fever. Very non-specific fever, she didn't need any medicine also. So we don't know how much importance to give to that fever. Not documented and didn't need medicine. And the child was fine. So again, that is a relatively minor complaint. Okay. Next. Yeah, 10 days back for 2 days, she said clearly. Right? Okay. Can it be a GI infection? You had abdominal pain, now you got fever. Unfortunately, half the people would call it GI infection and start treating with antibiotics. What are your thoughts on calling it a GI infection, meaning a dysentery?
But there is no loose stool or vomiting.
Very good. It will come tomorrow.
Has subsided.
No, but suppose you were there on that day. She came to you on the fourth day of the illness saying that 3 days of this abdominal pain and today I've got fever.
The abdominal pain will be more severe and more spasmodic type and troubling to the child.
Very good. What else? What is the symptom of a dysentery?
Blood in stool.
There's no loose stool only, no. And you said, I said it will come tomorrow. So that's not the timetable of a dysentery, that you start getting pain, then for 3 days only pain, then fever. All that is not the timetable of a dysentery. So out of question. So it's not a GI infection at all, right? Okay. Now your neurological complaints. So difficulty in walking in the form of patient is dragging her left leg while walking and difficulty in running. 2 days later, patient had fall while walking towards the side due to weakness in the legs. One leg or both legs?
Firstly, the symptom starts from the left leg because she was dragging the left leg, and then uh, she has history of fall in either side.
Okay. So now what do you make out of this? So again, what should be your thought process first? Anatomy you want to make out. So anatomy, whether this is a problem of lower motor neuron or upper motor neuron, then we'll go further. So what do you think?
The only weakness in lower limb without uh, loss of consciousness or without matlab, uh, the without seizure or without focal neurological deficit, sorry, without altered sensorium, so the cortical involvement is less likely. And
Okay, good. Now, suppose this is a hemiplegia because she was dragging her left leg. So you could get a hemiplegia without loss of consciousness.
yes, sir.
So how will you confirm or rule that out on history?
So she has history of truncal involvement in form of she has history of difficulty in getting up from lying down position. So the truncal involvement uh,
No, so you're right. But typically, if you have a hemiparesis, hemiplegia, what are all the things that are involved? Lower limb, then
upper limb,
and
facial.
facial. So ask for that history, no? Whether there was any facial deviation to one side, whether when there was dragging of the left leg, was she able to do everything with her left hand? So that will tell you whether this is a hemiplegia or it is not a hemiplegia, right? Even without loss of consciousness or etc. But you're right. So it is less likely CNS, more likely peripheral. Peripheral as in spinal cord or beyond. But still, spinal cord can be UMN or LMN, right? So that still remains to be decided. So then you have said difficulty in standing from squatting position. What would that mean?
Involvement of the proximal muscles of
Very
leg.
good. Very good. So proximal muscle involvement. Then uh, slippage of slippers while walking. What would that mean?
Distal muscle
Yeah.
involvement.
So you got proximal as well as distal. Okay. So now we have to decide what I just said, whether it is UMN or LMN. We have decided it is not CNS. But in spinal cord at one level and below that. So that would be UMN and otherwise it could be LMN. So how will you decide that?
There is a
So what are the things in history that point to a spinal cord involvement?
radicular pain or
So radicular pain is not strictly cord involvement. It is involvement of the roots, right? The roots are emerging from the cord. So radicular pain is that. It is seen even in GBS, where it's not strictly the cord that is involved.
back pain. She has back pain, spinal. Uh,
Okay, so what all can back pain mean? We are still on history, so back pain can mean two, three things.
muscle pain or
Okay, so neuronal would be restricted to the back. Neuronal as in same as root pains you are saying, no? So that would be restricted to the back. It would be along the leg, lower down, etc. Right? So local pain is indicative of what? Muscle what?
Could be related, could be because of the muscular spasm of that area, or due to compression of the uh, vertebral disc, or due to any bone pain of that area.
Why do you get a muscle spasm? Suppose you get a muscle spasm in the back. Why do you get it?
because of inflammation or
This is a very important principle to understand. Inflammation where? You're right.
inflammation around the muscle or uh,
So you get a muscle spasm for the same reason that you get neck rigidity, for the same reason you get guarding rigidity in acute appendicitis. Now tell me why you get a muscle spasm.
inflammation of nerve innervating the
So wherever there is inflammation which will cause pain on movement across that joint. So when your meninges are stretched and there is going to be pain, the muscles go in spasm to prevent that movement. So same is guarding rigidity for appendicitis, same is this, and same is the back spasm. So they don't want the back to move. So it is a self-protective mechanism to try and reduce the pain. Same is in the hip, you get a fixed flexion deformity. So all these muscles are trying to prevent movement across a particular area to try and reduce the pain, right?
I think spinal cord compression would also present almost like asymmetrical problem, fall, etc. And there you decide whether the story is a very short, acute onset or gradually worsening onset. This is an acute onset. To that extent, what is acute onset? But it's not ultra acute onset. That means it's not traumatic. Therefore, it must be coming up in 2-3 days' time. So my question first to you is, we said we started with abdominal pain, and then 2 days later the fever came. I think it's a complication of a cause of abdominal pain, which is getting infected, isn't it? Fever coming up after something is likely to be a complication, right? I fall down, get injured, 2 days later I start getting fever, so it is a local infection.
Because the abdominal pain is not that severe, and fever is also mild to moderate grade and undocumented,
But coming after 2 days,
but it
any
living on its own, not requiring medication.
infection starts with fever. Infection doesn't come 2 days. Suppose I have a tonsillitis, I don't complain of fever while pain while swallowing, and 2 days later I get fever. I get the fever to begin with. So in other words, yeah,
Hello. The fever was non-specific means the mother uh,
And what would have happened?
could have been persistent.
the point I'm making is two are not related. Okay. And that already discussed that constipation must be there earlier, or when there is some illness coming up, probably there is a disturbed diet intake, therefore probably some weight pain, and it has nothing to do with that. So the story starts really with fever, though yes, the parents said first constipation. Two are unrelated, and therefore this is self-limiting. So obviously a viral infection. Okay. So could it be a myelitis? After all, poliomyelitis is a myelitis, is a spinal cord disease. So
Yes.
can this be a myelitis?
It can be myelite.
So, so why are we thinking about anything else?
We should ask for any sensory involvement and bowel bladder disturbances.
And mostly the poliomyelitis like could be any viral infection. It's fairly an acute onset, asymmetrical. And would it have pain also? Or it's only motor? Motor. So why is that? Polio is a motor only, no? Isolated motor. Why should there be pain? In other words, again, pain is due to a spasm. Okay. Inflammation causing need to protect and therefore possibly a spasm. So then why not this like a poliomyelitis like illness? And you should send 3 days a stool sample for AFP, etc.
There's no history of vaccination or
You agree
recent
that
immunization.
we are thinking about a low motor neuron, you're thinking about flaccid paralysis. The rule is 3 days stool sample.
We have to still take further history, examine. It might be acute flaccid. It could, if we find flaccid paralysis, anyway, this child would need to do all that, right? So right now we can't be sure. And what other point which sir said, can it be transverse myelitis? So one you said was bladder. of transverse myelitis usually and this child. So transverse myelitis, everything would happen almost suddenly and then can't move both lower limbs, can't do this, can't do that. Here you said first left side, then little bit on the right side. So that is a little against transverse myelitis, right? Okay. So then we were discussing whether it is UMN or LMN, and then you said uh, root pains would favor LMN, right? Okay. Now, we also talked of proximal muscle weakness and distal. Proximal is a characteristic of what? Which anatomy? Lower muscle, lower motor neuron, muscle disease. And distal is a characteristic of nerve. So, can this be nerve disease or can this be muscle disease?
Distal and proximal both are involved.
Very good. Excellent. So when you have muscle disease, it is only proximal weakness which stands out. When you have nerve disease, only distal stands out. When you have both, it can't be either. So it has to be higher up, which is involving everything. So probably nerve roots. So right now we are close to nerve roots as a possibility. And spinal cord, we will check maybe on examination further, right? And you already said there is truncal weakness. Then you said tingling sensation. Okay. So, Udani sir's one statement you must always remember that anterior horn cell atrophies. Okay. Roots pain and nerves tingle. So these symptoms or signs, they are like stamps, hallmarks. So anterior horn cell disease, you must have fast atrophy or wasting. Okay. Roots pain and nerves tingle. Okay. Then you said back pain. Okay. Fine. Rest is all okay. Come. So now give us your provisional diagnosis.
11-year-old girl presented with weakness of bilateral lower limb age, immunized till date with sensory involvement in form of tingling numbness in bilateral lower limbs without history of cranial nerve involvement or bowel bladder involvement without involuntary movement with intact sensorium is a case of acute onset paraparesis with progressive myelopathy, most probably due to acute transfer myelitis or autoimmune demyelinating disorder, compressive myelopathy, or GBS.
So why have you put compressive myelo? First of all, from the history that we got, what is in favor of myelopathy? On history only we are saying.
There is distal and proximal
Weakness.
weakness, and it is involving progressively involving the trunk. So,
The same thing can happen in GBS, no?
it's a GBS is
No,
also.
agreed. I'm asking you, you in your last summary line, you have said with progressive myelopathy. We are just discussing that do we have evidence to call it myelopathy? I'm just trying to say what we have is both lower limb weakness. We have some tingling numbness. We do not have clear cut sensory disturbance. Tingling numbness is a nerve related problem, not a sensory affection of the cord, right? We don't have bladder bowel, right? And we don't have injury, all that, and sudden acute and all that. So I thought that with this history, we don't have enough to call it myelopathy for sure right now. You can give 80 transverse myelitis as one of your DDs, right? But don't call it that it is a myelopathy, because if it is GBS, it's not a myelopathy. You get my point? Okay. Now, why have you brought compressive also? Means on history.
Because sir, it was involving first left side and then right side. So it it compressive myelopathy, it's chronic disease, but it is asymmetrical. So I have put compressive also in my DD.
So you're right. So the odd point is that the asymmetry, but it has happened in just 2-3 days, which is a little unusual, right? Okay.
On examination, febrile, pulse rate 92 per minute, regular rhythm, good volume, no radio, radial, radio, femoral delay, RR 22 per minute, regular, saturation maintained, peripheral pulses well felt, extremities warm, BP between 5 to 50th centile.
सत्या पहले चल के दिखाएगी, मराठी बोल दे. दूंगा.
After treatment, she was able to walk, but initially she was unable to walk.
As of today, did you notice anything in the gait, or you think the gait is normal? Or
Gait is not normal. She was uh, dragging her left leg, not dragging, but the gait is abnormally circumduction.
परत चाल. She thinks there's circumduction, so everyone look at that.
Is not very prominent circumduction, but
In gait. What all things you observe in gait?
The pace with which the child is walking, speed of gait, then how is she keeping the feet? Like, is it a wide based gait or uh, a stomping gait? Whether is she able to feel the sensations while walking? Then
she's stepping the foot like
The step length, like stride length, and if she's swaying to either side, and if she walking in a straight line.
Arm swing along with the gait.
and the position of foot, like she was um, slightly tilted. She was walking with slightly tilted left foot.
So you said most of the things, but you should have started with saying that you look at the strike and the stance. Okay. Well, you know everything. Chalo, come. Come, come.
The way the foot is placed while walking.
First heel first and toes first.
So strike is heel first or toe first, or third one is whole thing as just one flat stomping, what you said, right? And what is the stance? Stance is that when the next step is taken, what happens to the leg in or the other leg at that time? So that is your stance, right? So these are the things plus all what you said. So in her case, what was obvious was that her leg was kind of externally rotated when she was walking. So that was one. And the second, I thought there was a bit of recurvatum, as in her knee was going a little too much in extension, which will happen if her weakness is just recovering. So if she is hypotonic and not really 5 but 4 plus, then she would do that, to walk, right?
Also, while walking after two steps, she is finding some support to maintain her
Correct.
balance.
But which is not ataxia, because if it would have been seen in other things. So that's what I'm saying, that her power is probably 4 plus but not 5. And that is why she's, after a few steps, she wants to look for support, right? Okay, so that is one. That was the gate. Now come, what about other things? So general, how do we start usually with examination? So observation quickly. In a CNS case, it is very easy. Come. It could be all normal, but still come. Both of you do it together. Come.
The child is sitting comfortably in the chair with um, legs,
Hmm?
hands, dorsiflexion. नहीं, plantar है ना, plantar flexion.
So I told you, no, last time also, but I think you were not there. So all these postures and all, I could sit in any position, no? So that doesn't mean it's a permanent position, right? So unless it becomes obvious that she can't move that, you don't insist that that is the position. So whenever you start talking, first thing you talk of is build. So growth. So what do you think?
Just very
Normal growth.
normal growth.
Sick or not sick?
Non-sick.
Not sick. Very good. Now, any particular paucity of movement or anything that you notice? So she walked and there is no paucity of movement that you can make out, right? In relation to CNS, we are discussing CNS. What all can you see on the face?
Alert,
All active, responding to surroundings.
conscious, oriented.
And some CN neurological examination also you can do only by inspection.
She is smiling, no deviation of angle of mouth, no drooling of saliva, blinking normally, eye movements normal. Uh,
So about half the cranial nerves are done. They're all normal, right? Without touching. Okay. Then what do you want her to do?
No no negligence.
stagnant.
So now all this is done. Now come closer and look at the tone. So examine for tone in the, say, left lower limb. You have that bed to make her lie down. Hmm. Shall you show us the tone examination in the lower limb? Okay, face.
Um, uh, Inspection, the child is moving the legs normally, the bilateral legs extended, and there is no abnormal movements. And on
Examine
palpation,
for tone. So what is the first step that you do, especially in lower limbs and when it's a little older child? Log
inspection.
roll. So what is log roll?
Do the roll the legs and then see for extensive movement or decrease movement on the ankle. So this is normal. This is no extensive movements or decreased movement.
So in the lower limbs, increased tone is seen best where?
Ad- Adductors.
Yeah, adduction at the hip. Okay, adductor spasm. So how do you look for that? Make her knees folded, both her knees fold. This also fold. Now take both the knees far away. Yeah, very good. Yeah, very good. Is there any spasm? No. This is the most sensitive in the lower limbs, and in the upper limbs, pronation, supination. Okay. No, you should hold the arm. You're looking at the wrist joint. So don't hold on the wrist joint. Hold the other side here. Okay. So tone is normal. Power. Okay. Show us reflexes. Ask her, ask the father, and then. So at least say that I want to expose, because in the exam you should say that. Right? You want to see the muscle. Okay, do it directly. Very good. So now what should be the next step? Clonus. Very good. Look for clonus. No. Some improvement in method. Okay, and where will you hold? Not there. Hold here. Beyond that muscle and joint. Okay. See, ऊपर पकड़ और टोस पे पकड़. हाँ. And move this along different positions to get it. Okay, doesn't matter. But that side you got definitely, right? Okay. Upper limbs. Don't do supinator there. Huh? Do it on this side. So don't, instead of doing this, you could keep it here and then do it from here.
The reflexes are brisk and there is well sustained clonus present. The tone is normal.
Sure. ही नहीं लेने का, इससे कर बॉटम से with non-sharp one. ऐसे नहीं. Why is your left hand not using? Hold it at the ankle. थोड़ा नीचे. हाँ, बस. So this one is extensor, right?
Yeah.
That side we are not sure. You got extensor? Okay. So extensor, plantar, abdominals. Tell her, explain always. So this need not be sharp. If sharp will cause pain. What is the stimulus for the abdominal reflex? What is written in the books? What are you supposed to do? Strike or stroke, gentle stroke. So stroke means just touch. Exactly, yeah. Touch with that hammer cup, so rounded part. Huh? Absent means what? So you'll have to check sensation because we are discussing spinal cord as one of the anatomies. But in upper motor neuron disease, superficial reflexes are either altered or absent. Altered is plantar extensor. Altered means different from usual. Or absent, which is abdominal reflex absent. So it goes in favor of upper motor neuron disease. You got brisk reflexes, you got clonus, right? Sensory now, how will you check? You got cotton? Okay, check proprioception. Any change in her technique? Anybody? थांब एक मिनट बेटा, आराध्या थांब. No. Technique of holding the great toe. Hold from the sides. Why? When you are moving up, your pressure of the thumb up is giving her a sensation, no? So hold from the sides. उस साइड से पकड़ना, नीचे जा तू. हाँ. Now hold.
Keep it so that, yeah, that's right. And then now ask her. Yeah. Yeah. And then ask her what is. No. Then stop it. After 2, 3, you stop and ask her up or loud.
है कॉटन है नहीं है ठीक है उससे कर टच anything else you want to show any time you are there बस बस बेटा उठून बस is there any tenderness along the spine or any paraspinal muscles or this tenderness
But the sensations are normal. There is no definitive level at which she doesn't get sensation.
help her to come down थँक यू भाऊ होशील बरी होशील हा चल
So on systemic examination, higher mental function, conscious, child is oriented to time, place, person, memory, intelligence, speech, normal. Cranial nerve examination, no evidence of any cranial nerve involvement. Motor examination, bulk of the muscle equal on both sides. Tone is normal. Power in upper limbs by 5 by 5. In lower limbs, power was 3 by 5 on arrival, but now it is 4 by 5. And trunk power is on right side, it is 4 by 5, and left side 3 by 5. Reflexes, brisk, plantar reflex, extensor on both sides, uh, and there is a well sustained clonus. Abdominal reflex absent. Sensory examination, touch, pressure, temperature, vibration, proprioception is normal. Back pain present over T4 to T8 level. There is no meningeal signs, no cerebellar signs. Gates, then other system within normal limits. Diagnosis: 11-year-old girl presented with weakness of bilateral lower limbs. with history of fever and abdominal pain, with sensory involvement, um, uh, with back pain, with brisk deep tendon reflexes, with absent abdominal reflex, without cranial nerve involvement or bowel bladder involvement, without involuntary movement, with intact sensory. The case of acute onset paraparesis with progressive myelopathy, left more than right, most probably due to autoimmune demyelinating disorder, acute transverse myelitis or compressive myelopathy. But compressive myelopathy is less likely, most likely autoimmune demyelinating disorder, infectious.
Typical GBS is a motor problem, and the sensory is very transient. So that is number one. Plus, it's a lower motor neuron lesion. This is certainly an upper motor neuron lesion. So you come to a conclusion that this is not central nervous system, but the spinal cord, and you would be happy to see whether there is any absolute area of hyperasthesia, and below that some changes, but which we have not found out. So maybe she's developing something, unless you say she's improving something. Both would look at the same time, but the story is too short for us
She
to.
says she has already improved in her power.
Yeah. So if she's improving, then which compression is improving? Okay. Which is most unlikely. What was the tone like? Spastic?
On admission,
On admission, also the tone is normal,
So,
not spastic.
so I think clinically there are signs of upon lesion to show it. Only thing is that I'm sure because of constraints of time, maybe if there was a sustained clonus, we would have said it's
Sustained clonus.
okay. Because sometimes ill sustained clonus may be normal. Okay.
Well sustained clonus on
So,
admission.
so I think clinically, history-wise, it was certainly not a compressive myelopathy. Even on examination, it's not a compressive myelopathy. And therefore, the question is it something like a transverse myelitis, which has been aborted and started improving either with or without that? But transverse myelitis is an acute condition. This did not look acute. It looked asymmetrical. So starting from one side going up to the other. So possibly we have a combination of what history suggests and what examination suggests. So I think if you look at an improving situation, then compressive myelopathy is not possible. Even history,
Improved after medication.
yeah,
no,
but
that is fine. But what
compressive.
compression though will not improve even with medication. That's what sir is saying.
So compressive is not likely. If it was autoimmune, then it's not compressive. The only condition that would improve is autoimmune disorder, either by itself or by your IVIG or whatever. And therefore, acute onset, I would have said it's an acute immune mediated, very likely like a GBS. What was not fitting in GBS is a persistent sensory disturbance. And therefore we bring in something like a transverse myelitis, but not of an acute onset. I think
Even sir, the upper motor neuron signs wouldn't fit into GBS.
yes, and
And
therefore
sir, could it be that it's a ADEM type minus the E?
yes. So acute. After all,
Disorder without encephalitis.
edema is like transverse myelitis. When it's only the spinal cord, you call it transverse myelitis. So it is acute immune mediated myelitis, but not compressive, right?
So the CBC was within normal limits. Uh, CBC within normal limits. There the MR in another hospital there was MRI done. They did MRI. So it suggests diffuse long segment expansile enhancing intramedullary spinal cord lesion extending from C3 to D10 vertebral levels. Um, and the differential considerations include MOG antibody associated disease, neuromyelitis optica spectrum disorder, or idiopathic or post infectious transverse myelitis. Like it is longitudinal extensive transverse myelitis, LETM. So it can be autoimmune demyelinating like MOG antibody disease or
Yeah, so MOG antibody and all is subsequent, various possibilities. Being a girl child, like they said, it could be neuromyelitis optica spectrum also.
visual disturbance.
Correct. So there is no visual disturbance as of now. Multiple sclerosis in older women will also come like this, then this will get better. Till you have a second episode, you wouldn't come to know that this is the first episode of multiple sclerosis. So all these DDs are possible. Clinically, I think what you said is right, your first one. So only thing is to refine after your final diagnosis, after examination, you should remove compressive also and keep it as only autoimmune, right?
Thank you, sir.
Thank you. Good presentation and good discussion. Okay. Second case. Okay. Sharing this and or it's in the same.
Good evening, everyone. I'll be presenting a short case for today. This is a 6-month-old male child, first by birth order, born out of third degree non-consanguineous marriage, resident of Sion, hailing from Bihar, Muslim by religion, Sheikh by community. Informant being mother came for regular blood transfusion. The child is a known case of some blood disorder. Uh, The child was apparently all right till 2 months of age when the child started having fever. Since for 15 days, which was low grade, 101 degree, 100 to 101 degree Celsius, 1 to 2 spike per day, which was relieved on medications. Child was active in the interfebrile period. The fever was not associated with any complaints of cough, cold, vomiting, or loose stools. The child was active, feeding well, attaining well age appropriate milestones. In view of recurrent fever and increased paleness, which was not noticed by the mother, the child was investigated and told to have low hemoglobin on blood test. Child received first transfusion at 2 months of age. On further investigations, child was told to have a blood disorder and parents were counseled about the need for regular blood transfusion therapy. Both the parents were tested and told to have a minor form of the disease. The child was again admitted at 4 months of age for fever and increased paleness since 5 days. CBC was done suggestive of low HB and the child was again given transfusion. There's history of similar blood disorder in paternal uncle's son. There's no history of jaundice, abdominal distension, no history of increased work of breathing or pedal edema, no history of bleeding from any other sites, no history of irritability, no history of constipation, lethargy, no history of poor height or weight gain. Total transfusion histories, child has received total 7 transfusion in the last 4 months, 3 transfusions during the first admission, and 2 transfusions in second admission. There's no history of any transfusion associated reactions. ANC history, the mother was registered. 4 ANC scans were done. Anomaly scan was told to be normal. All the TT injections were taken. IFA supplements taken. No history of GDM, PIH, hypothyroidism, or any complications. There's history of one blood transfusion in mother in 8th month of gestation and HB of 8. Birth history, the child was full term normal vaginal delivery, birth weight of 2.8 kgs, cried immediately after birth. No history of NICU stay. There's history of neonatal jaundice present, for which the child received phototherapy for 3 days. Child was discharged on day of life 5. Child is immunized till 3.5 month of age. 6 month immunization is pending. All the developmental milestones achieved by the child are appropriate for the age. Diet history: the child is on exclusive breastfeeding, breastfeeds 5 to 6 times a day and 2 to 3 times at night, breastfeeds from one breast at a time for 10 to 15 minutes, and sleeps well after feeds. There is a family history of similar disorder in the paternal uncle's son. There's no family history of gallstones or any surgery. Socioeconomic history: belongs to lower socio-economic class according to BJ Prasad. Summary: 6 month old.
Go to the presenting complaints. You said fever at 2 months of age, no?
At 2 months of age, the child started having recurrent episodes of fever.
Recurrent means describe that
Uh,
properly.
for 15 days, mother noticed that the child was having fever, which was low grade. It was 100 to 101 degree. But it was relieved on medication. And along with the fever, the child did not have any cough, cold, or any other symptoms, loose stools, vomiting.
Documented fever.
Hi, yeah, documented 101, mother is saying.
So what did she do for 15 days?
She took medications from the local practitioner. So after medications, the fever was resolved. So she didn't do anything. But then she noticed that the child was looking pale also. So for that, she came to us in EPR and we did the investigation first.
What would be your thoughts? 2-month-old coming for fever for 15 days. And no other symptoms. Come on, what are your thoughts? What are the common causes of fever in a 2-month-old? Infection. So which infection is this? 15 days fever.
The fever was not like severe enough, so it like mostly it could be viral only.
No history of weight loss or other constitutional symptoms.
2-month-old where you'll talk of weight loss.
Not gaining weight. No.
That mother won't be able to make out, no?
Fever since 15 days, less likely infective. It is more like inflammatory.
Excellent. First thing is you should have said that 15 days fever for a 2-month-old. First of all, I would question that 15 days itself. But even if it is, it can't be any infection because a infection untreated in a 2-month-old for 15 days would have become so bad, so many complications, so many things. So the first thought process is unlikely to be bacterial infection. Now, can it be tuberculosis? Can it be viral infection? Can it be parasitic infection? Think of all that. Can it be malaria? What about viral infection at 2 months?
It will resolve on its own and it will not be for 15 days.
Very good. First of all, 2 months viral infection only is uncommon and it has to come from a family member, contact, etc. Those are usually respiratory viruses. So there will be a lot of respiratory complaints. Incidentally, which viral infection can have fever for 15 days? Not at 2 months. I am asking in general. EB virus, infectious mononucleosis. So not the age at 2 months and so on. So therefore viral infection is out. Yeah. Now tuberculosis, sir said. Low grade fever 15 days and
There is no other symptoms like cough, no cox contact, or uh, uh, if the build not
so see, cough will be there if the primary is in the lung. 2-month-old with tuberculosis, what are the possibilities? Where all can be the tuberculosis? Which all?
Abdominal lymph node or meningitis, TB meningitis.
If meningitis irritability or some symptoms should be there, the child should be irritable, not gaining, like the mother is properly saying that the child was very well, was up, gaining weight, age appropriate milestones, so less likely.
Less likely.
I think 2 months is an odd age for getting fever. That's number one. Now, the most important part of the history is what has happened in these 15 days. Has he been getting sicker and sicker? If not, then this is a low grade problem. Okay. Now, low grade problem is what? Low grade infection. Okay. Now, low grade infection is either congenital malaria, congenital TB, but that does not wait for 2 months to develop symptoms. That comes very early. And at that time, these congenital infections don't come with fever, but they come with hepatosplenomegaly or dissemination, or malaria would come with pallor. And therefore, congenital infection is unlikely. Acquired infection like TB, the incubation period itself is 6 to 8 weeks. So this child is only 8 weeks old. So imagine he got it in a maternity home from somebody else. Then it has to go through 8 weeks of incubation period before the symptoms start. So even that is unlikely. So infections are ruled out. Had it been an acquired malaria, it would not have gone on for 2 weeks. So we are sure this is not infection. If it is not infection, there are only two other things to consider as far as diseases are concerned. Autoimmune, which is very, very unusual at that age, or malignancy. Malignancy is also not common at that age. So my diagnosis is heat fever. Yeah, born at this period of time, the baby is getting heat fever. And all that you do is to put him under the AC room or under the fan, okay, and the fever will disappear. No other symptoms, nothing to go by. What's your comment?
About increasing paleness noticed by the mother, that is also, nahi, that like during the period only, but it became prominent in the last week.
I mean is that heat, 15 days of fever could be a heat fever. The question is, you need to ask more details of what kind of fever it is and how it is relieved. The heat fever is not going to be relieved by just paracetamol. It may have its own variation. Like in the early morning, the fever may not be much there because the nights have been a bit cooler. Then as the day comes up, the fever starts coming up. And on examination, the heat fever, it can be easily diagnosed. How can you diagnose heat fever on examination? That is the only fever where the periphery and the central part both are equally hot. Rest all fevers, moment the fever starts increasing, periphery starts getting cold. So always touch a foot and touch your abdomen, and if both are hot, usually it's a high fever and not just continuous 2 weeks. So finally, could it be hyperthyroidism? Hypothyroid, they feel cold. Hyperthyroid, they come with fever. Forget that hyperthyroid is not common at that age, but fever is not the only symptom. Diarrhea, weight loss, okay, sickness. So the point is that there are other fevers which are non-infective. So finally we come back, and now you said the mother has noticed pallor. Okay. Which means at 2 months this child has got pallor. So what kind of hematological disorder comes at 2 months of age? To me, it's thalassemia major coming up. So why not thalassemia? Would he get fever? No. And therefore, 2 months is just the borderline. 2, 3 months is the time when thalassemia present, but doesn't present with fever, present with pallor and abdominal distension. So possibly this is not. In which other hematological conditions with pallor present at 2 months? Thalassemia, no, because of fever. Leukemia, yeah, it may come that early, but which is a common out of the uncommon situations at 2 months. And that is a bone marrow aplasia. Okay, and the syndromic one. There could be a radial abnormalities. So those could be considered. There could be fever, there could be some. Leukemia is on card, yes, because leukemia can come with anything, and there is also congenital leukemia. So we'll keep it open like this.
So now you said that this child was given blood transfusions and then was told that this is a transfusion dependent situation.
Child will require regular transfusion.
So now, given this history from all which differentials which we discussed, can you bring in which one is higher, which one is lower?
Most likely it's thalassemia, which is thal major, which is coming up at 2 months of age.
Why not a bone marrow like a congenital aplastic anemia?
The child will be sick, but this child is active, alert, and non-sick on history.
Okay, what else? Sick, yeah, I agree, but then it depends on which series is affected, how much, right? So if the platelet and the WBC series are not very badly affected, then the sickness may not be very visible. But there's one more reason.
Um, there is pancytopenia, so WBC count if it less, then there is in recurrent infection, and there is if platelets are low, then bleeding manifestations can be there.
Right. What else? Is there any difference in the transfusion requirements of a bone marrow condition and a hemolytic condition?
More frequent transfusion in hemolytic disease.
Very good. The hemolytic always needs more blood transfusion because there's actual destruction. Whereas in a bone marrow situation, once you give, it is likely to last for a while till nothing more is produced and you need to give again types. So that's a small difference between the two. Okay. Here you said there's no abdominal distension, nothing. Now the baby is 7 month old, 6 months old. Okay.
I think the fever part is therefore needs to be really analyzed. I wonder whether it has nothing to do with pallor, which means there is a heat fever or whatever we said. Okay. But looking at fever with anemia, you would have gone on to bone marrow. And then requiring frequent transfusion is not a bone marrow. In fact, aplastic anemias may not need a bone marrow, may not need a blood transfusion. Leukemics also may not need a blood transfusion. So blood transfusion is required only for hemolytic. And if that is so early, then it has to be so. Could it be ABO incompatibility?
It will manifest on
Six
birth.
weeks, 6 weeks, 8 weeks.
Child is sick looking.
Okay. And therefore, but ABO can come up at 6 weeks, 8 weeks with both. And could it be RH plus ABO coming at 6 weeks? Or it should have come on first 2 days only. One protects the other. Okay. So the point is at 6 weeks you do consider ABO incompatibility, but if Keras is the strong point there. Here, fever doesn't fit in again. So, as you said, 2-month-old with fever, but no other symptoms and still maintaining life for 15 days looks like fever is fictitious or maybe really non-infective, non-inflammatory, etc. Right?
6-month-old boy, first by birth order, born of third degree consanguine marriage, resident of Dharavi, informant being mother, presenting at 2 months of age with recurrent fever and paleness, requiring regular blood transfusion, is a case of transfusion dependent anemia with family history of similar illness in the paternal cousin, and a birth and developmentally normal child immunized till 3.5 months of age, most probably a case of thalassemia. There's no history of jaundice or abdominal distension. So there's no hepatosplenomegaly for abdomen. There's no history. Yeah, hemolytic anemia. So
If early presentation, so it is possible that there.
So you've heard ineffective erythropoiesis. What is that? What does it mean, Mike?
There is defect in hemoglobin production because of the beta chains, and also there is some form of destruction because of the excess alpha chains. But the main defect is ineffective erythropoiesis. So jaundice would not be the initial symptoms. Like
So as the word suggests, ineffective. That means it's not effective. So not effective means erythropoiesis. So RBCs are not really formed. Before that only they are destroyed. So before hemoglobin is properly put in the RBC, it is destroyed because those only alpha chains can't sustain. When will you get jaundice? Once you have hemoglobin, it is broken down into heme and globin, then it goes to the spleen, then all that cycle, then you will get bilirubin production. So much before that, the RBC is destroyed. So thalassemia is a peculiar hemolytic anemia where there is no jaundice.
no history of increased work of breathing or pedal edema. No history of bleeding. Related to so it cannot be there is sacral
Can
edema.
say sacral edema, but don't say pedal. So what we are trying to teach you is that tailor your history to the age and the situation which you are talking. Don't just go mechanically, right? So it improves your quality. Next.
No history of bleeding from any other side.
Okay, so bleeding, or more importantly, means overt frank bleeding will be difficult, but what will be
Petty
very good. So that is what you have to
No
ask
history of
for. Then,
no history of irritability.
okay.
No history of constipation or lethargy. Hypothyroidism.
So hypothyroid for what? Pallor or fever or what? Hmm? Tell us why you thought of it. Because you only said that in spite of the fever, baby was happy, feeding well and all that. So normally, forget this child. How does a hypothyroid behave at 2-3 months of age? Lethargy, no, and not feeding well and sleeping all the time.
No history of poor weight or height gain.
Correct. So poor weight is fine. Mother will make out. How will mother make out height gain in a 6 month old? Hmm? Can't. So don't ask that.
On examination, the child is lying comfortably in the mother's lap. Child was off febrile, heart rate was 128, regular rhythm, good volume, equal on both sides. Uh, Peripheral pulses well felt. Respiratory rate was 34 per minute, regular. Saturation was 99%. Extremities were warm. BP was at 50th centile. Anthropometrically wise, weight was 5.8 kgs, which was less than -3 standard deviation. uh, Height was 62 centimeter, which was -3 to -2 standard deviation. Head circumference was 41 centimeter, which was -2 to -1 standard deviation. Weight by length was -3 to -2. So at 6 months, it is impression is moderate acute malnutrition. uh, Pallor was present on head to toe examination. There was prominent forehead, frontal bossing was present. Rest of the head to toe examination was within normal limit. On per abdominal inspection, shape was normal. The central inverted umbilicus. On palpation, superficial palpation was soft, non-tender. On deep palpation, liver was 4 centimeters soft below the right subcostal margin. Spleen was 5 centimeter palpable below the left subcostal margin for firm in consistency. On auscultation, normal bowel sounds were heard and tympanic note on percussion. Rest of the systems are within normal limit. Uh, Summary diagnosis: 6-month-old child, first by birth order, born of third degree non consanguineous marriage, brought by mother with complaints of recurrent fever and increased paleness requiring recurrent blood transfusion, is most probably a case of thalassemia major in a normal by birth child, immunized till date, developmentally normal, with family history of similar blood disorder with hepatosplenomegaly. uh, to rule out cecal beta thal or severe HS or HB thal. Uh, this was the not sure. It was a pre-trans CVC when the child presented to us. It was suggestive of HB of 2.3 with not MCV of 62. So it was micro cytosis. Counts was 50,000 and platelet was 266. So on PS, it was hypochromic, anisopoikilocytosis, polychromic, and the corrected WBC count was 17,500. The retic was 2.4%, and there was nucleated RBCs present. We had sent child's HPLC. So HPLC confirmed there was HbF concentration was 85.1 and A2 was 5.1%. So it was suggestive of beta thal major homozygous. We had also sent parents HPLC, which was suggestive of beta thal minor traits. We had sent since the age of presentation is very like 2 months. We had sent enzyme membrane studies at NIH, which turned out to be normal, and we had also sent a mutational studies, which was uh, suggestive of beta globin gene mutation in the IVS 1:5 homozygous mutation.
We'll do one or two other exercises. So this baby has liver spleen and is pale. Those are your findings, right? So and undernutrition. So actually your percentiles, I don't know how you get such severe percentiles. 6 month old you said and 5.6 kg, 5.8 kg. So how can it be less than -3? I can't understand. So something is wrong somewhere. Then 62 centimeters height you said, right? So fine, it's on the lower side. And head you said is 41. So depending on the birth head circumference, 41 could be okay, right? So all these things you need to be a little more careful, accurate in your thing. But what I'm asking is, suppose you are not told this history of blood transfusion and you are kept this baby in the exam. How will you discuss the possibilities? You have this kind of a baby, 6 month old, whatever these growth parameters, and you have liver, spleen, and pallor.
Hepatosplenomegaly with fever, with paleness.
Fever nahi. We're not talking of history. We're talking of only examination. Only examination. Whether we can talk of any other DDs or it is only hemolytic anemia. Huh? Okay, torch infection. So we are just learning how to argue against or for different things. So one is saying torch infection. We'll discuss whether it's possible to argue. Anything else? Can it be liver disease? It can be. So then argue for or against liver disease. Anything else? Could be malignancy. Could be storage disease. No history, only examination. 6 month old liver, spleen, pallor. Could be storage disease. So now start discussing. How will you discuss for or against any of these?
So in liver disease, abdominal distension, ascites, and
Abdominal
jaundice.
distension is there, no, little bit. Liver, spleen is there, means some distension has to be there.
On examination, ascites, and there
It is
will
not
be
yet.
jaundice.
It is not yet. Portal hypertension is not yet developed.
Jaundice will be there.
Not all liver disease have jaundice.
Liver
liver disease have
tenderness. Liver tenderness if it is infective.
Chronic liver disease or acute? What are we talking of?
Acute.
Acute liver disease will have what? What is the hallmark of acute liver disease? Jaundice. Right? So acute liver disease is out. There is no jaundice only. We are at the most talking of chronic liver disease.
Isolated liver disease will not have spleen.
Hey, spleen hai.
Splenomegaly. Isolated liver disease will not have
Why?
splenomegaly.
They have
Also.
portal hypertension, no? Cirrhosis with portal hypertension.
If portal hypertension is there, then there should be ascites.
Very good. Very good. So that is one. Second,
Feeding well again goes against liver disease.
very good. Then what else?
Any
How
other
many?
history of abnormal colored stool or urine that would have been there.
Sapometry wise, also the child is undernourished and FTT or severe acute malnourished.
That is in favor of liver disease.
The child will be more sick looking.
I think if this child had come to us at the first time with pallor, etc., we would not have said transfusion dependent, right? And that is how we would look at that. At that time also there must have been a liver and spleen. Okay. Now, if your length of 62 is right, then the question is, was it a full-term normal delivery? If so, 2.5 kg, 50 centimeters, then it looks very unusual. So the point is, are we having a short stature child? Weight is not too bad, but the length is certainly less than normal. So I'll call it short stature. Short stature is your hypothyroid. And you are saying that is not hypothyroid. To me, short stature is hypothyroid and anemia also. Right? So the point is, we need to be very sure where we are. Very likely the length may not be so low. Okay, we are not doubting your findings, but if it's 62 centimeters, then it's the short stature. And if it's 5.8, then it's certainly not too bad in weight. So length is even worse than the weight. So that is number one. So it's not malnutrition really. Okay. So at 2 months of age, a liver and spleen would not have been a hepatocyte disease because there is no time to have it chronicity there. So it's not a hepatocyte disease, it's not a biliary tract disease. Could it be a venous obstruction? No, venous obstruction at that age is an acute onset but cherry, which comes in infancy, but that comes with ascites and portal hypertension. Then, if it's the pre-sinusoidal portal hypertension, then there would have been only spleen, and the manifestation would not have been anemia again. So, when you have a liver and spleen, it has to be at that age a reticuloendothelial system involvement. Now, what does that mean? So, that means chronic infection is one, storage is another. So, storage at 2 months of age is too early. Storage takes time to develop. Even an infantile Gaucher comes with about 3 months, 6 months with only splenomegaly. And much before that, you can't have a bone marrow involvement with pallor. So congenital malaria still stands high on my card. If I saw a 2 month old, 3 month old with anemia and liver and spleen. TB doesn't look like that because again we said anemia is not a prominent feature of TB. So storage is out. Chronic infection, torch, torch again coming with severe and pallor is unusual. Liver spleen, yes. Again, you ask for a history. What was the weight at birth? Whether it was a low birth weight full term baby, then it could have been some possibility of congenital. So congenital malaria stays at that time. I don't think storage is likely. Then the question is really is there any other hematological disorder, like we said, congenital leukemia, but if it's sick looking, then that. So I think what we learn out of this child is fever is possibly to be rechecked, how significant fever it is, or it's only the mother's perception and the pallor is the only thing. If pallor is the only thing, then add one more fact.
Sir, kindly unmute yourself. We cannot hear you. Hello? We cannot hear you, sir. Kindly unmute. No, sir, not yet.
Okay, forget the PPT, but so few other things I wanted to revise. You said count, WBC count was 50,000. No? So leukemia, no? Why WBC count was 50,000 and hemoglobin 2? So 100% leukemia.
Created RBCs were present, so counted as WBC in the Coulter machine.
Okay. So that
Collected
is
count was 17,000.
17,000. Okay. Then you said MCV was 62. So microcytic. What about MCV? Sorry, MCH.
It's also low. I'm not
Okay, fine. So microcytic hypochromic could be iron deficiency also.
RDW was
So what is RDW?
15.
What is the concept of RDW? Anyone? What is the concept of RDW?
Variation in the size of the RBCs. So in thalassemia, we expect all the RBCs to be of the same size, microcytic hypochromic. So there is not much variation in the size of the RBCs. That is
In which thalassemia we expect them to be same? Thalassemia major or thalassemia trait?
thalassemia.
Thalassemia trait. Okay. So microcytic hypochromic could be iron deficiency or thalassemia. RDW normal is thalassemia trait. RDW high is deficiency anemia. RDW very high is thalassemia. So in thalassemia also major RDW is high. It's in fact very high because as you know the peripheral smear of thalassemia major is all kinds of cells. It's a dirty smear. So small, big, ada, teda, this, that. So therefore your RDW will be very high, right? And also RDW is measured in two different units. So the confusion is what is the range of those two units? So what is normal RDW?
10 to 17 femto.
So 10 is I think too low, but check on that. But it's around 14 normal. 14, 15, 14 around normal, right? And what is the other unit? This is femtoliters. And what is the other unit? CV, coefficient of variation, where the normal RDW is in the 45, 50s, right? What I am trying to say is, in thalassemia, your 14 wala units ka RDW reaches 40. And you might just pass it off as, ke, acha, this must be that unit, the other unit, CV. So don't get that confusion. Okay? So that is one. Then what else you said in your report, CBC? Huh? Menzer index. So Menzer index is for what? Why do you use it? Where do you use it? So in other words, you have a CBC which shows a little less hemoglobin, and if it shows microcytic hypochromic anemia, so you have to decide whether this is iron deficiency only or this could be thioyltrate. Should I investigate for thioyltrate? That is where you use all this, Menzer index and other things to decide. So essentially, what is the concept of Menzer index? So RBC count is high in Thal minor. In spite of the RBC count being high, your hemoglobin is low. That is the problem in Thal minor. Whereas in iron deficiency, because there's no raw material only, there will be less RBCs formed. So the count is bound to be low. Right? Okay. Anything? Okay. Any other questions you all have? Okay. And online, any questions or any comments? Okay. So we'll stop here and we'll meet on next Thursday again at 5 o'clock. Thank you.